All right. Good evening, everyone. This is United Medical ACO. My name is Kemal Erkan. Today is November 9th. It's another Wednesday with our wellness webinars. As usual, I have Caroline Weber and Donna Gunkel with me. And today, Dr. Ripple Handal is going to join us for our panel discussions. So how are you guys doing?
Excellent.
Very good.
Thank you.
All right. So before we start, I just want to make sure that, well, 4 of us are already here, but Tim Luku as our physical therapist and also Roxana Portal as our social worker. She is part of the program. This is something we do every second Wednesday of the month, and then the fourth Wednesday we do have our support group, and we made some updates on the support group, the way that you can actually participate for our patients. So you can actually directly go to the Zoom link and then register yourself, and that's every fourth Wednesday. Again, Dr. Handal is our program director. Time to time, he joins us. So Dr. Handal, today we are gonna, I think we already covered this once, Polycystic Ovarian syndrome we are gonna discuss. And then Caroline is gonna give us updates on the diet side of it. So we can start if you are ready.
Yes. All right. Well, good evening, everyone. So this is a topic which we don't discuss that often, but it's very prevalent. As shown on this slide, the polycystic ovary syndrome is the most common endocrine abnormality in the reproductive age females. In different studies, it's been shown that may be present in 4 to 8% of the women. Recent studies have shown that maybe it's close to 20%. More important is that a lot of physicians, they don't look for this syndrome, and 70% of these type of females with PCOS, they remain undiagnosed. And later on in their life, they present as type 2 diabetic individual, and then we start treating them. And then when you go back into their history, then you find out, oh yeah, this problem started very earlier on, but it wasn't picked up. This PCOS syndrome affects more commonly seen in obese individuals. So 28% of the people will be obese with PCOS. And it can happen in some lean females as well, like 5%, but they're very insulin resistant. This is considered the most common cause of infertility and ovulatory, means the person does not ovulate. So they're not having regular menstrual periods, there is no ovulation. So that's the reason of their infertility. So this is the most common cause seen in 90 to 95% of the individuals who present to the infertility clinics for their workups. So let's go to the next slide. So what's the underlying reason? What happens in these individuals? So insulin resistance plays an important role. By insulin resistance, we means that the insulin is there, but it's not working the right way on the receptors where it's supposed to lock on and do what insulin does, means moving the glucose across the cell membrane. So insulin resistance plays an important role in these individuals. There is in 50 to 80% of patients with PCOS will be insulin resistant. Then high insulin level works on the ovaries to make more male hormone testosterone. And then also insulin resistance leads to decrease in the binding proteins. These are called sex hormone binding globulin. these binding protein binds their testosterone. So it's not freely available to go across the cell membranes. But once the sex hormone binding globulin levels goes down, then the free testosterone, which is not bound to the proteins, is freely available to exert its action and does what the testosterone is supposed to do in a female. And which is the second one, hyperandrogenism. So testosterone levels being high, or they may be within normal range and still inappropriate for that female. This high testosterone is seen in 60 to 80% of females with PCOS. So these are the two key players. And then in addition, as I explained, more people with obesity may have PCOS. So obesity does play an important role as it worsens the insulin resistance. So people who are more obese, they tend to be more insulin resistant as compared to someone who is more within the normal body mass index. And then when they are more insulin resistant, then again, the same process starts where there's increased androgen, testosterone production, and causing all the abnormalities. So these are the three things which play an important role in causing this syndrome. So how do you diagnose someone with PCOS? So this is for your own information. If some individuals who are listening to this topic, if they're family members or any personal history like this, they should definitely get in touch with their physician and try to sort of catch this problem early, which again goes undiagnosed quite often. So the National Institute of Health criteria suggested that it's oligomenorrhea, means menstrual periods are not happening regular, they are delayed. Some people may get like every 6 weeks, some people get 8 weeks, like 3 months, 4 months. So they are not menstruating regularly, so there is no ovulation. So that's one of the criteria. And the second one is they may have clinical or biochemical signs of hyperandrogenism. So either their testosterone levels will be high, or they have signs of high testosterone, which means facial hair growth, acne, hair loss. So they can present like that. And this is after excluding other etiologies, other causes of these type of problems, which is shown at the bottom of this slide. These are rare disorders called the congenital adrenal hyperplasia. Sometimes they can be testosterone secreting tumors. Cushing syndrome is one where there's excessive amount of steroid production in the body. Then some people may use these androgenic or anabolic drug abuse. They use it from outside. Low thyroid can cause some of these problems. High prolactin level can cause these type of problems. Or there are some syndromes of severe insulin resistance. So again, you have to exclude these other etiologies before you say, okay, yes, this person has PCOS. Then there is other European Society, actually, the European Society also has the same type of criteria, but they mentioned that you need to look at the ovaries as well. So do the ultrasound and see if there's polycystic ovaries, in addition to the other two signs which are described on the top. And the third one is the Androgen Access Society position statement. They mentioned that there's either obviously hyperandrogenism, they have facial hair growth, or they have increased testosterone levels, they have ovarian dysfunction, and exclusion of other androgen excess. So their criteria is almost same as the NIH criteria. But the main 2 points is irregular periods and clinical signs of high testosterone, or their blood levels are high, but they may not express all those signs of high testosterone. So next slide. So these patients with PCOS, how they present? They can be different ways. Sometimes as I explained earlier, they will be obese. Some people have infertility problems going on. They are unable to lose weight. So they can be psychological issues. They have reduced, the quality of life. They have poor self-esteem. They may be depressed or anxious about like not getting pregnant or why can't they lose weight. Then they can be reproductive features, which means they may come to the clinic by saying, okay, I'm having some facial hair growth, which started just recently, or I'm losing more hairs. Other female may come and say, okay, I can't get pregnant. We have been married for 3-4 years and I can't get pregnant. Or they did get pregnant, but they had like early miscarriages. Then the other person, someone else may present with the metabolic type of picture, which is they unable to lose weight, blood sugars running a little bit on the high side. They are not diagnosed with diabetes yet. This way, if they present earlier on. They have metabolic syndrome where they have more central adiposity, so they have more belly fat. If you look at their blood levels, their good cholesterol is low, triglycerides are high. And then as the disease progresses, then their fasting blood sugar remains elevated, so they develop pre-diabetes. And then they go into a diabetic range, which then you say type 2 diabetes. Then these patients down the line, they are at high risk for cardiovascular disease. So again, they may present later on with heart attack, stroke, abnormal lipids, which I explained earlier. Obesity is mostly central obesity, so they're not able to lose weight. So again, this type of syndrome affects almost every part of the body. So may present differently depending upon the person who is sitting in front of you. So let's look at the ovarian functions, like what happens. So as I explained earlier, there can be oligomenorrhea, where there's irregular periods. They're usually seen in 70 to 80% of the females with PCOS. That usually starts in adolescence. So that will be a typical teenager girl going to the clinic for, okay, I don't have regular periods. I can't lose weight. Then they may start, when you're talking more in detail, some people will say, okay, yes, I have noticed some facial hair growth. I'm having more acne problems. So every person will present differently. There'll be 40% of the patients, which they may come to the clinic by saying, okay, I don't have any periods for the last 1 year. So that can be another form of severity of this PCOS. In general, females should have like at least 3 to 4 cycles per year to protect the endometrium. Otherwise, if they don't do like this, there is buildup of the endometrium, and later in their life, they can be risk of like endometrial cancer. So that's why that's important to have regular periods. And some individuals may have that, as I explained, there's buildup of the endometrium, then there is sudden heavy bleeding for days, which may happen periodically. So they may say, okay, I don't have regular periods, but then after every few months, I bleed so much that it drains me out. So these are different type of presentations can happen. Then, as I explained earlier, a lot of people goes to infertility clinic. They tried their best and still not able to get pregnant. And usually they are anovulatory, they are not ovulating, and that's the reason for the infertility. Or 60% of the females with PCOS, they are able to get pregnant, but they may take time to conceive. And as I explained earlier, that there are a lot of people with PCOS are obese, and obesity is an independent factor which can decrease their chance of getting pregnant. So that's why in these individuals, usually we aim for helping them to lose some weight by whichever means, so that they have a greater chance of conceiving and carrying on pregnancy. Next slide. So the hyperandrogenism, that means elevated testosterone levels. So there are numerous theories going on where maybe there's insulin resistance. There is some issues going on with the pituitary gland, which is the higher center in the brain, which sends signals to the ovaries to regulate it. So one of the hormone coming from the pituitary gland is the luteinizing hormone, or LH. Usually these levels are elevated in individuals with PCOS. That works on the ovaries to stimulate more testosterone production. Then the insulin resistance, then the insulin levels are high, to overcome the insulin resistance, and high insulin drives the ovaries to make more testosterone. That all these features then leads to decrease in the sex hormone binding globulin, raises the free testosterone, which passes across the cell membrane to further cause these problems. And then ultimately, there is impaired ovarian follicle development, so they don't go through that cycle of ovulation and end up with not having any period. So hirsutism, which is defined as facial hair growth at the abnormal areas, that is seen in 60% of the individuals. Acne may be seen in another 1/3, and some extreme patients, they may have more male pattern alopecia seen on their forehead, on the scalp. Next slide. So there is a score, this is called Ferryman-Galloway score, which gives individual numbers to the amount of hair growth seen in a female. So there's different areas as shown on this slide, on the mouth, around the mouth mustache area, then in between the breast area, then above belly button, that's where the facial, where the hair growth, if it's excessive, will show up. Then in the inguinal area down, then on the arms, back of the legs, back of the trunk, and then lower back. So you'll be based on these scores. If the score is more than 6-8, that means that person has more unusual hair growth as compared to a normal female. Next slide. And one thing I want to point out in the previous slide is that some females may say, oh yeah, I have this increased facial hair growth, but this is familial. It's my mom had it, my sister has it. So some people, you have to get some family history too. Some family in certain type of ethnic backgrounds, they may have more facial hair growth as compared to someone else. Then looking at the metabolic features of this PCOS patient, as I explained earlier, in the lipids, they can be high triglycerides, they carry low, good cholesterol. Then insulin resistance is seen in 50 to 80% of the patient, which is more commonly seen in obese individual as compared to the lean patient with PCOS. They are at much higher risk for developing pre-diabetes and type 2 diabetes. And here it's quoted over here, like the prevalence rate of 31% of developing pre-diabetes and 7.5% for type 2 diabetes. Then during their pregnancy, patients with PCOS have high increased risk of developing gestational diabetes. They have more insulin resistance, so they may need medication, insulin during their pregnancy period. Down the line, they have, because of all these risk factors, they have increased risk of cardiovascular disease, heart disease, stroke, peripheral vascular disease. And then another thing is this runs in family. There can be increased risk of metabolic complications in first-degree relatives. So always good idea to take good family history, talking about their parents, talking about their siblings. There may be other sister who may be older, younger, that may also carry some of these features of the PCOS if the patient is diagnosed with PCOS. Next slide. So this just basically gives a rough idea of like what I just discussed. So genetics play a role, family history of diabetes, lifestyle, they're obese. Lifestyle means they are more sedentary, eating high carb diet. That leads to these hormonal changes with increase in the androgen production, high testosterone. That leads to like facial features, hirsutism, acne, then psychosocial issues with their body image, self-esteem, depression, anxiety, working on the ovaries. So they don't ovulate, follicles are immature, they don't develop fully. That leads to menstrual irregularities. And then on the other hand, the right-hand side is the insulin. By insulin resistance, that has an indirect effect also on the ovarian follicles. And the other pathway shown is developing diabetes and cardiovascular and metabolic syndrome. Next slide. So once someone is diagnosed with PCOS by all these features, then how do you basically treat it? So as told earlier, it's the insulin resistance plays an important role. So by any means, if you lose weight, your insulin resistance will get better. So losing at least 5 to 10% of your body weight, that will nicely bring the blood sugars down, will improve the insulin levels. Usually combination of both aerobic and the muscle strengthening exercises, they are very helpful in improving the blood sugars. In general, ask them to avoid high, like foods with high glycemic index, because then high blood sugars will trigger more insulin release and then will perpetuate the issues with the ovaries making more androgens. So high protein, low carbohydrate, and low glycemic index diets are helpful. Putting them, it's a good idea to send them to a nutritional classes so that they have a better idea about their calorie intake, how to eat the right type of food, and to help lose weight. So they will have better outcomes in the long term. Next slide. So in individuals with irregular cycles, not having periods, then as I explained earlier, anybody can have 5 to 10% of the body weight loss. That nicely improves the insulin levels, testosterone levels goes down, and they may start cycling off their own. So that's an important first treatment that we try in these individuals. Others one, we usually try to put them on birth control pills. The birth control pills also helps to regulate their cycles, and then also avoids that buildup of the endometrium and shedding in between. If they are not having any bleeding, then in between you have to give them on progesterone for 10 days so that they have a bleeding, so that it doesn't lead to buildup of the endometrium and down the line risk for endometrial cancer. Metformin is also a drug commonly used because it helps to lower the insulin levels. So it does improve the ovulation and their menstrual irregularities. And then when these individuals are planning for pregnancy down the line, then they should follow with somebody from the reproductive endocrinologist. So then they can plan if they're able to conceive of their own, well and good. If not, then there are other treatments available with the in vitro fertilization to help them conceive. Next slide. Somebody having more facial hair growth, hair loss, then for the facial hair growth, cosmetic therapy, laser treatment they can use. We use a medication called spironolactone, which blocks the effect of the testosterone on the hair follicles. So, but this is to be used only in individuals with not planning for pregnancy, because if somebody gets pregnant on spironolactone, that's not good for the fetus. So it's very, very important that those individuals should be on birth control pills so they don't get pregnant. Metformin also helps to lower the testosterone levels. So along with the using the birth control pills helps to improve the hair growth or the hair loss. So they can be used in combination with the oral contraceptives. Next slide. So these individuals, once they have been diagnosed, we usually treat them with these medications, try to incorporate good, healthy lifestyle changes so they keep their weight down. That may decrease the risk of developing diabetes, heart disease down the line. So it's a lifelong surveillance for these individuals. It's not like one time, okay, they got pregnant, it's a done deal. But later on, these individuals, if not followed properly, you will see them later on in your clinics, like diagnosed as having diabetes, or down the line coming with very high cholesterol levels, heart attack, and then you take a detailed history and say, oh yeah, probably this woman had PCOS, which was not picked up previously, and now we are seeing the end results. And then on top of treating that individual, taking a good family history and trying to tell them that maybe your family members are at risk for developing this PCOS or metabolic syndrome, heart disease, diabetes. So these type of counseling is very important to prevent long-term complications and mortality or morbidity. So in this slide is just the same slide. It's showing where we can use. So lifestyle is the critical component, and these individuals should start very earlier on in the process so that we can avoid a lot of these changes, decrease the insulin level, decrease the androgen levels. Metformin works on the insulin levels, helps to lower the insulin levels, and that's how it helps to prevent the onset of diabetes, and then obviously works on the ovaries as well to improve the menstrual disturbances. Then if somebody has down below the androgens, if they have hirsutism, acne, lifestyle, lose weight, using oral contraceptives, which will lower the free testosterone, because with the oral contraceptives, it increases the binding protein. So the free testosterone level usually goes down. So it does help with improving the facial hair growth and acne. And then we can use the anti-androgen, which is the spironolactone on top. With the menstrual disturbances, lifestyle, metformin, birth control pills, and then later on, this clomiphene is used for getting pregnant. So that can be used in combination with other medications like metformin to help patient conceive. And then under diabetes and cardiovascular disease, as I mentioned earlier, these individuals should be followed regularly by their family physician or other specialist to prevent long-term complications like diabetes and its related complication or cardiovascular disease. So if this disease starts from teenager years, if you pick up early, then it's to continue through their reproductive life when they're trying to conceive, risk of gestational diabetes, then after delivery, risk of developing pre-diabetes, diabetes, heart disease, blood pressure, cholesterol problem. So it's not a simple disease that we just say, okay, yes, that's what you have. It can become a serious disease. So it's important that whosoever you are seeing, talk to them, get yourself evaluated properly. If not, see a specialist and take action earlier on to prevent long-term problems. So I'll stop over here. Thank you.
Dr. Randall, thank you. As you were going through the slides, I was, it's my medical school, right? So with these live sessions. So one thing that you mentioned in the beginning, 70% of these cases, they go through undiagnosed. So people, they are not looking for medical treatment or they are not aware of these. So, but from what you explained so far, these are pretty visible, there are pretty visible effects of this disease. So are they, maybe the patients are just maybe embarrassed to come to the providers and the physicians or look for treatments, or are they just, do they not care?
It can be both ways. I mean, the patients also don't go forward with all these type of problems they are facing. And a lot of physicians are not trained to pick up this diagnosis. So until unless it's a very real serious problem where you see, okay, a lot of facial hair growth, they'll say, oh yeah, it's let's do the workup. But a lot of times physicians don't do the full workup. They just, I mean, okay, this is a problem. Oh, it's a weight related problem. Let's make you lose weight. I mean, just like to brush it off and do the minimum workup. So again, I mean, if anybody, a lot of times we don't take proper history, their menstrual history, or patients can easily say, oh yeah, I've been under a lot of stress. I've been having these weight problems and irregular periods for years. This is all related to my stress in my life. I'm going to college, working 2-3 jobs. So they find an excuse that why this is happening. I'm not taking care of myself. Stress can, everybody knows, stress can cause hair loss. So maybe I'm under a lot of stress. So they also give reasons for why I'm having this problem. I'm not exercising, eating the wrong food, can't lose weight, and maybe this is what the reason is. So it's both from patient point of view as well as from physician point of view. A lot of physicians don't know about this diagnosis. They've read about it, but don't look for it.
Mm-hmm. And we do something similar on obesity treatment, morbid obesity treatment, but you also mentioned that 28% of these patients do have obesity. So it's kind of, I think there's this, in some cases, maybe the social stigma of the disease itself, when even sometimes with, like, not just for this, but even for men, with our colonoscopy, routine colonoscopy. I'm going to get one tomorrow, and no, I can't talk about it. So there's always this little pressure, I guess, on the patients, maybe from society or from other things that other things that we learn. I don't know. So even someone who's in the medical field for so many years, for me, do I put the colonoscopy on my schedule, or do I not tell people? But now I'm just telling everyone on live. So it's just there's that, maybe like being more comfortable. And then I think I always tell people that talk about the issues, talk about the problems. Don't wait until the last minute. So we don't want to find this out when it's already at a higher level, like more severe, right? So the patient shouldn't be finding this out in your exam room. So because that would actually just delay the treatment and and getting better soon. But I don't know. Understanding patients is difficult, including myself.
I mean, to just give you an example about the facial hair growth. I mean, the females feel embarrassed about saying, okay, I'm developing facial hair growth. So a lot of times when I take a detailed history, then they say, yeah, it's been happening for many, many years. I just used to shave. I didn't want it to have other people look at me and say, oh, what, I'm growing a beard. So they go for laser treatment without getting any formal diagnosis made. They will keep on doing those things until then time comes in their 20s trying to get pregnant and can't get pregnant. Then they start looking into it.
Yeah, that's all right. So thank you. And Caroline is going to talk to us about the nutrition part of this, and then see how nutritionists actually can help process.
Awesome. So first, I just want to talk about what is a dietitian's role in PCOS and diabetes care. So more than half of women with PCOS, they develop type 2 diabetes by, I think, the time that they're 40, from the last thing I read on the CDC. So it's a dietitian's job to work with patients to get symptoms, to help reduce the effective symptoms and reduce the risk of developing any additional complications like we've talked about. But PCOS can look pretty different for every person. I see a wide variety of patients with different symptoms and different struggles. So it's why individualized medical nutrition therapy is very important. So we'll break down some health challenges that some patients with PCOS face. First, starting with insulin resistance, we've got a good detailed history tonight of insulin resistance and PCOS, super common in our PCOS patients that we see. And also some links to chronic inflammation as well that we see in patients with those inflammation markers in blood work. So we're really working on increasing that low glycemic index foods. We work with anti-inflammatory foods, which we'll get into in a little bit. And that has been shown to help with the symptom management and decrease of overall additional complications coming later. We also see a lot of weight maintenance issues. Sometimes one of the biggest challenges we see is the weight reduction, right? There's a lot of misinformation out there that patients get access to online about fad diets and different things like that, which can actually hurt their metabolism if not done correctly, because there's no one size fits all diet. So that's why we want to make sure that we do individual counseling, figure out your nutrition needs, and then treat after. So weight loss ends up being even more challenging for those PCOS patients. And many factors, genetic predisposition, insulin resistance, PCOS patients might have a lower basal metabolic rate compared to those without, which means, the minimum energy requirement you have to do your daily activities might be lower. So we also see extreme cravings as well. So you're hungry, you're not satiated. So we work with ways to make sure that we're fed frequently. Our cravings are decreased by, we'll talk a little bit about mindful eating as well, but in those certain ways as well. So one of the also really big highlights, which Dr. Hundel spoke about a little bit, was increased anxiety and depression. We also see a lot of eating disorders, primarily binge eating disorder among patients with PCOS. It's not as simple as just lose the weight. It's a lot more complicated than that. So anxiety and depression rates do tend to get higher since it is a frustrating process. I believe I think it was 455 women with PCOS found that 60% had binge eating disorder, which it's pretty wild to talk about, just because it honestly it goes missed just because you have that stigma of the weight gain. So it's our job as dietitians just to work with patients to identify their nutrition goals, minimize those symptoms that we went through, and then identify potential areas where an eating disorder, disordered eating patterns might exist. We also see a lot of weight cycling too, just because, the fad diets that are out there going around, we see yo-yo dieting, which can affect our metabolism. So we want to make sure that we're not having any harmful effects from any quick fix diets, which could increase binge eating behavior, psychological distress, and possibly even harm our blood sugar levels as well. So we want to make sure we're monitoring all that. So next slide, please. What are our goals for treatment? So first off, there's certain things that we like to go through just to make sure we have them under control, especially stabilizing blood sugar. So that's one of our first steps in making sure if there is insulin resistance, right, we're choosing foods that support a good blood sugar. I think it was a 2019 study that I had read. Over 1,000 women with PCOS were surveyed, and a majority of the women didn't have any nutrition guidelines they were following, or half of them were in a restricted diet pattern. So we want to first identify what our goals are to focus on and then come up with a game plan for that treatment. So the first step would be stabilizing the blood sugar, reducing androgens, reducing inflammation, and then working on symptom management as well. So we want to make sure, how do we achieve these goals, right? There are certain things that we can do with our diet to help balance out some of the symptoms and challenges we go through. Next slide, please. So like Dr. Hundel said, diet and lifestyle modifications are huge primary treatment approaches for women with PCOS, but surprisingly, there's not an optimal diet out there, right? There's not some PCOS specific diet that we counsel on. A lot of the time, those eating plans just include lower glycemic index foods, modifying carb, fat, protein ratios in the diet. Even without weight loss, we want to see that we're having a better control of blood work. So some certain things we want to work on are adjusting our macronutrient distribution. So a lot of the times we work with, 40 to 45% carb, 20 to 30% protein, 25 to 30% fat. The number could change based on your diabetes risk or your control. So that's why our needs are individualized. So not a one size fits all diet again. Primarily a lower carbohydrate dense diet has been shown to be great success with maintenance and blood sugar control. We still want a little bit of that carb in there because that's your main source of bodily energy, but really focusing on the type of carb. So those low glycemic index carbs, which contain fiber, whole fruits, whole grains that take longer to break down in your body and don't cause such a quick rise in blood sugar like our simple refined carbohydrates that we've talked about in the past. A lot of the time, our medical nutrition therapy, we also look at how much we're eating, but the types. So making sure that we're falling back on those whole grains, good complex carbs, and choosing protein at every meal and snack. So making sure, we even do this with our diabetes counseling as well, making sure your carb and protein always go together. They love to be in a pair because you have slower digestion. So making sure that is a good way to support your blood sugar to prevent any, ups, downs that would prevent diabetes in the future, hopefully. So making sure we have a protein and a carb together. Also choosing color. So a lot of the ways to get good antioxidants, good vitamins and minerals are making sure we're choosing a variety of fruits and vegetables. We aim for probably at least 5 fruits, veggies a day, portion sizing those fruits out. We talk about ways to, the higher sugar fruits we eat in smaller quantities, spread out the timing in between. The lower sugar fruits we can have more often in a larger quantity, but we talk about specific serving sizes. Those whole grains, the low glycemic index carbs, essential vitamins and minerals. We often use a plate just like this one on the slide, pretty similar to the My Plate model, where half of our plate is vegetables. We've got a fourth or a little more than a fourth of protein, and the smallest portion is carb. We still want that carb because when you pair carb and a protein and some fats all in one, they work together to keep you satiated, which that will help cravings, that will help overeating, binge episodes, that will help all of those things. So we want to make sure the plate is balanced to give you everything you need. You don't really need to follow a keto or really, really low carb diet. The goal is to choose minimally processed foods like quinoa, farro, brown rice, oats, those types of things that have the high fiber content. Some plans that you might find online do cut out gluten and dairy, especially if they, increase symptoms. But I would definitely talk before eliminating an entire food group or an entire section of your diet. Definitely talk to your physician and your dietitian about it. Just because if you eliminate certain things, you might be losing out on certain nutrients. We want to make sure there's no nutrient deficiencies there. Whole fruits is one that we touch on a lot, just because fruits can sometimes get a bad rap because they do have sugar in it. So we want to make sure we monitor the sugar, but juice for sure is not doing any good things for our blood sugar. I always like to, I think I've said this in the past, I say it every time I talk about juice. Imagine it takes 8 to 10 oranges to make 1 glass of orange juice. You're getting that 8 to 10 oranges sugar, like it's just endless sugar without all the benefits of the fiber. So eating a whole fruit, eating a clementine instead of a glass of orange juice, right? You're going to gain so many more benefits from that. So it's a great way to help control your blood sugar. So incorporating varieties of fruit, right? We see a lot of things we'll talk about in a minute, anti-inflammatory foods, a lot of antioxidants in berries, in cherries, in those different types of fruit. So making sure those whole fruits replace any kind of juice in the diet. And then we love our nutrient-rich fats and omega-3s. They help in a lot of different ways. So they can help to improve your mood. There's evidence that helps insulin sensitivity, cholesterol health, hormone health, inflammation, even helps our skin. So incorporating, omega-3 rich items like fish, walnuts. I would talk to your physician or talk to your dietitian before supplementing, just because sometimes supplements aren't regulated. So you want to make sure that you get a good pure supplement. And incorporating these fats regularly in your diet. So it could look like, tuna on a Tuesday, you could have some nut butter on a snack. So incorporating some omega-3s regularly can definitely show some benefit. And next.
I think that's all we have. Oh, no, we have one.
Yes. We got lots of nutrition interventions here. So I talked about anti-inflammatory foods. I get these questions a lot just because it can sometimes be a buzzword of, chronic inflammation. What does that mean? Like, there is a certain blood marker, the C-reactive protein, that can pop up. And so sometimes we see that a lot with PCOS patients. So we want to make sure that we're limiting foods that may cause inflammation, such as fried food, sugary foods, processed meats, and increase those anti-inflammatory foods, which basically just have antioxidants in them. So leafy greens, citrus, berries, fatty fish, and walnuts. There's a great study, I think it was compared to women without PCOS, women with the condition have higher levels of the insulin and inflammatory markers. So a 2015 study, the researchers investigated the use of anti-inflammatory diets in PCOS. In the study, I think over 100 women who were overweight with PCOS ate a calorie-reduced diet for 12 weeks. The diet had 5 small meals, and I believe the macronutrient distribution was 25% protein, 25% fat, and 50% carbohydrate. The diet was designed to include more high fiber foods with an emphasis on those anti-inflammatory foods, and limit the chicken, the fish, the red meat, and added sugars were limited, while those like fish, berries, nuts, those types of foods were prioritized. The results were really awesome. The mean weight loss was about 7.2%, with significant reductions in your cholesterol, blood pressure, fasting blood glucose, that C-reactive protein, which mark the inflammation in the blood, and those reduced by about 35%. And then 63% of those women regained menstrual cycle regularly. So that was really great evidence to see through just diet change. And then there's also the DASH diet that we sometimes recommend. That's the dietary approaches to stop hypertension. It often includes a lot of anti-inflammatory foods. So a lot of those foods rich in antioxidants. So women who follow the DASH diet for 8 weeks saw a significant reduction in insulin, CRP levels, and improvements in waist circumference measurements from some of the studies that I read. So all with diet, emphasizing certain foods over others and choosing them more often can really help benefit symptoms, improve weight loss, blood sugar, all of those things. Increased meal frequency. This one, a lot of people skip a lot of meals. And so for some people with certain conditions like PCOS or diabetes, we don't recommend that just because we want your blood sugar to be stable all day long. We don't want any bumps and jumps. We want to make sure that increasing the frequency in small, frequent amounts will allow your blood sugar to be more stable throughout the day. So regular eating can also reduce cravings. It can also reduce overeating. So a lot of the time you might find those binge episodes because you've skipped all this time and then you go overboard and end up eating too much, which of course isn't great for the blood sugar because you're getting all of that carbohydrate and broken down into sugar, which causes your blood sugar to jump up. So we want to make sure that we include 2 to 3 small meals, 1 to 2 snacks. So in counseling, individual counseling, we work on finding different methods to make that work for individual schedules since everybody is different. And then mindful eating, which is huge for our patient population who might be struggling with eating disorders, binge eating disorders with PCOS, because we often see those sporadic eating and dieting behaviors. There's just a boatload of diet plans online that you could just Google and find. And it's common for some misinformation to be present. And so we want to, there's no correct diet to fix PCOS. You can't just fix it. Patients need a healthcare team just to work with them on each individual aspect of it to get comprehensive care. So those fad diets, they're often restrictive, can cause that yo-yo effect, which are harmful to your metabolism, can cause a poor relationship with food. And then you end up getting undernourishment and deficiencies. We definitely don't want that. But when we mindful eat, we experience food in real time, right? We take perspective and we slow down, we taste our food, we get a better relationship with food, and we identify specific tools to reduce the feeling of guilt surrounding disordered eating patterns. So it's kind of an all-encompassing effect of when we mindfully eat, we're having better weight outcomes just because we're avoiding those disordered eating behaviors, the overeating, the binge eating, the restrictiveness, and we're in a sense healing our metabolism through food, which is really nice. Mindful eating, short cap is just eating with limited distractions, creating an experience around eating, and the tendencies, reducing the tendencies of overeating or using as a coping mechanism, such as boredom or stress. And then Dr. Hunnell mentioned physical activity, and that's huge. So including cardio with strength training can definitely help your PCOS symptoms. We talk about ways to get moving with at least 30 minutes of moderate intensity physical activity most days of the week. We talk about how to go through seasons. Right now, the big hot topic is how do we transition into winter? It's dark so early. Where do I exercise? When do I exercise? We talk about ways to do that. Good for your blood sugar, good for improving symptoms, and good for weight maintenance. So great. And lastly, considering supplementation. So this should be consulted with your physician. A lot of the time dietitians preach food first mentality, but for PCOS nutrition, we do recommend working on those lifestyle options first before jumping into those expensive supplements that say they'll, cure everything, right? But we do need to take into account there might be some nutrient deficiencies. There's certain supplements, have been shown to work for fertility or cholesterol or hormone regulation. So they might be beneficial, but definitely consult your dietitian and your physician just to make sure you get the best brands, the best purest forms. And that way you can have the best care without having to, spend a plethora of money on supplements that may or may not work. So in summary, PCOS, endocrine disorder that causes a variety of distressing symptoms, including that insulin resistance, chances of developing diabetes. But dietary strategies, they can improve the quality of life for people living with diabetes and PCOS. And the modification is primarily using food as medicine, but also being part of a team, a collaborative healthcare team, because we all work together to make sure that patient symptoms are managed and complications are limited. Thank you.
Thank you, Caroline. as I'm listening, all I can think of is because we do so many different presentations and it all comes down to the same, like there has to be some moderation, some good balance with our physical activity, the way that we eat, what we eat, when we see the doctor, when we see the nutritionist, and from Medical ACO standpoint, we have all these already in place for our patients. In fact, we are the only group practice whose accredited for the diabetes program. So we have 3 full-time dietitians/nutritionists. So and when we work with the physicians from the nutritionist side, it actually is the kind of like the best mix in a way that, but how actually we can increase the patient benefit from the treatment, because it's the teamwork. And even this event itself is trying to support what we may be missing in some cases, so that maybe patients can watch and better understand some of these things, and hopefully we can reach out to more people. Anything you guys would like to add?
I just wanted to say, kind of elaborate on what you were talking about, Kemal. You know, we hear this all the time, right? We talk about it in every one of our webinars, but diet and exercise truly are the keys. You know, when we say diet, it's really more healthy eating, although we know that that could be more expensive, but our dietitians can help you with, you know, being able to eat healthy on a budget. We have quick tips that help walk you through those things. So there are ways to do it if you're motivated and ready to make that change. We can help you with the tools and resources that you need.
All right. Well, again, thank you, Dr. Handal, Caroline, and Donna. So our next event for diabetes is for our support group, which is 2 weeks from now, and I think that's isn't that the Thanksgiving Eve?
It is.
It is. So I don't know.
It can be a good thing too, right before the holidays, because a lot of times people need the support as they head into the holidays. So, you know,
this time we do actually, if you guys would like, we can actually push that to the 30th, which is still in November, and it's a Wednesday. So that may be better from that point, just because people are, I mean, also you guys are going to be busy with your preparation and all that, so we can. All right, well, thank you again. Right. So we'll be back in 3 weeks. Bye-bye.
All right, thank you.
Night.
Yeah.